Mabuhay! My name is George Calixterio. Today I'm going to present to you a case study analysis. The case is about James, a 19-year-old male presenting to hospital with diabetic ketoacidosis known as DKA. I will discuss about the pathophysiological process using the concept map, the pharmacological interventions applied, and the nursing care plan for both the acute and chronic stages, and how we are going to provide holistic and culturally safe care for James. Diabetic ketoacidosis is an acute and potentially life-threatening complications of diabetes mellitus, commonly associated with type 1, but type 2 is also susceptible. It is caused by a critically low insulin level and usually triggered when diabetic patients undergo further stress such as infections, inadequate insulin administrations, or cardiovascular diseases. It may also occur as the first presentation of diabetes in people who did not know that they had diabetes and therefore did not have insulin treatment. Glucose is the major source of energy for our body. It comes from digestions of carbohydrates and is carried by the bloodstream to various organs. Insulin is a hormone produced by beta cells of the pancreas and responsible for driving glucose into cells. When insulin is deficient, glucose cannot enter the cells. It stays in the blood, causing a high level of blood sugar while the cells are starving. In response to this metabolic starvation, the body increases the levels of counter-regulatory hormones responsible for clinical manifestations. First, they produce more glucose to supply energy to the cells. This is done by breaking down glycogen into glucose and synthesizing glucose from proteins and lipids. However, as the cells cannot use glucose, this results in more sugar in the blood. And as the blood sugar level exceeds, the ability of the kidneys to reabsorb is affected, resulting to electrolyte imbalance. It overflows into the urine, taking water and electrolytes along with it, known as osmotic diuresis. This triggers the increased kidney filtration to excrete sugar in the body, resulting to various clinical manifestations. This results in the large volume of urine, dehydration, and excessive thirst, resulting to significant weight loss. Second, they activate lipolysis and fatty acid metabolism for alternative fuel-producing ketone bodies such as acetone, a volatile substance that gives DKA patient's breath a characteristic sweet smell. Ketone bodies, unlike fatty acids, can cross the blood-brain barrier and therefore can serve as a fuel for the brain during glucose starvation. However, they are acidic. And when produced in a large volume, it overwhelms the capacity of the blood plasma, resulting in more metabolic acidosis. And as the body tries to reduce blood acidity by exhaling more carbon dioxide, there is a deep labored breathing known as osmotic breathing. This is another compensation mechanism for the high acidity that moves hydrogen ions into the cells in exchange for potassium to increase potassium levels in the blood. But as potassium is constantly excreted in urine during osmotic diuresis, the overall potassium level in the body is eventually depleted. However, this can be treated by administering insulin and infusion of sodium chloride and potassium supplementation, of which James had. As you can see from the map, it details the treatment path of insulin therapy, fluid replacement, and electrolyte correction. This is applicable to James' treatment, which involves key pharmacological intervention including insulin, sodium chloride, and potassium infusion and supplementation. This means that IV insulin infusions such as atropine must be the main feature of the treatment for DKA because it inhibits ketogenesis, lowers blood glucose levels, and corrects acidosis over time. IV fluid like isotonic saline or 0.9% sodium chloride was given to James from the outset for restoring circulatory volume depleted by osmotic diuresis. In DKA, potassium supplementation may be normal, but total body potassium is low. Potassium is driven into cells with insulin therapy, and careful supplementation is required to avoid hypokalemia. These interventions essentially reverse the metabolic derangement in DKA and stabilize James, our patient. In the acute phase, airway, breathing, circulation is our priority. Nursing measures include dehydration, glucose and electrolyte management, and complication monitoring, which means continuous observation of his vital signs and neurological status, strict recording of fluid balance to see evaluation rehydration, measure blood glucose and ketones every hour, administer insulin and potassium according to prescriptions, and also, along with physical treatment, we cater to James' complete human needs. When he is stable, continuous chronic management should be in place, including his educational, psychological, emotional, and social support. By providing culturally appropriate resources for understanding diabetes, stigma avoidance, and care plan adherence. For example, educating James how to take insulin and monitor blood glucose to create diabetes self-management plan. Schedule follow-up with endocrinology and diabetes educators. We have to cater to James' psychological and emotional support as well by giving reassurance, listening, and advice for counseling in store. This may be the first health crisis James will have faced at the age of 19. For social support, taking into consideration his lifestyle, his studies, and his friends, it was part of the plan to link him to youth diabetes support groups. We have to consider a culturally safe care relates to James' background, values, and preferences, respecting all of these things. We have to use non-judgmental, plain language for trust building. If James belongs to any specific cultural group, we will look into his beliefs around illness, food, and drugs. We make sure of his empowerment regarding personal involvement in care decisions. Importantly, we must provide supportive, inclusive care environment. Inform his family because with family, it helps to supplement understanding and support for James. Lastly, in managing DKA in James' case, teamwork is crucial and multidisciplinary team is involved, which includes endocrinologists for diabetes management and insulin regimen planning, dietitians to help understand carbohydrate counting and glycemic or sugar control, nurses for ongoing assessment, monitoring, and education, the pharmacist to ensure the safe insulin administration and checks for interactions, social worker or psychologist that supports James' mental health and adjustment to chronic illness. Such collaboration effort ensures that James has physical stability, emotional well-being, and is ready for self-care back home. And here are my references. Thank you so much, and I hope you enjoyed the presentation.